Hey guys, this is Dr. Rapoff. I got another installment of my online lectures. This one we're going to talk about tranexamic acid. So what is TXA? It's actually an amino acid analog. It basically acts like an antifibrinolytic. This preserves the fibrin. The fibrin is what helps us make clots and helps with the platelet plug. Here's the clotting cascade. I don't want you to remember any of this stuff here. All I want you to know is fibrin causes clots, plasminogen, plasmin, all this stuff. This helps with fibrinolysis. That's what helps break down the clots. But this is exactly what we're trying to block because we want to keep the clot in this trauma patient. What's the dosage? It's 1,000 milligrams over 10 minutes. Should look like this vial here or this vial here. Confirm what you have on your trucks. That's 1 gram or 1,000 milligrams over 10 minutes. We'll talk about the hospital dosing here in just a second. What's the indications? It's trauma associated with hemorrhage. If their systolic blood pressure is less than 90 and or heart rate greater than 110 in your suspected trauma patients, there's only a handful of places that you can lose a significant amount of blood. You can't lose the significant amount of blood in the head, but in the chest, in the stomach, in the legs, and then certainly on the floor. Here's the adverse events. PE, MI, DVT, CVA, renal cortical necrosis, renal artery occlusion, all things associated with clotting. But again, this is things are hitting the fan, need to give the medication type of situation. So these are all relatively negligible. What's the contraindications? These are kind of hard stops. Hypersensitivity to the medication. This is a relatively new medication, so I've never seen anybody have any hypersensitivity reaction to it. But upper renal tract bleeding and subarachnoid hemorrhage, two things that we most likely won't know from the field, but things that we may know from the hospital side, and certainly a reason for us to stop the drip in the hospital side. But where does this come from? It started with a trial. It was about 20,000 patients. It was a CRASH 2 trial, if anybody ever asked you or talks about it. It basically showed the mortality was reduced from 16% to 14.5% at the 28 days. The NNT, that means number needed to treat. That's basically how many patients that we need to treat with this medication to save a life. It's only 68, which sounds like a lot, but considering when you got a medication like aspirin, where we give this medication to every single chest pain patient, it takes 385 patients to have a actual outcome. And there's medications out there that we have that are close to almost 1,000 patients we have to give the medication. So in terms of the cost of the medication and how many lives it saves, that's actually relatively good for number needed to treat. Here's the current indications we're using TXA right now. Our ENT folks are using it like crazy. Our OB-GYN folks are using it like crazy. And a lot of times when you get these trauma patients, they're most of the time young, healthy people that we don't have to worry about the clotting disorders and the clotting cascade, because these people they're young, they're healthy, they're not at risk for blood clots, but these are the ones that we can save lives, and we know this medication's efficacious and it's safe. So the dosage is 1 gram over 10 minutes or 1,000 milligrams. The hospital dosage is 1 gram over 8 hours, and if you really want to go forward and really want to let our hospital folks know that you know what you're talking about, something to load yourself with. BP less than 90, heart rate greater than 110 in the trauma patient equals lives saved. Best of luck. Be safe out there, guys.